My name is Ari Friedman. I'm Assistant Professor of Emergency Medicine and a Senior Fellow at the Leonard Davis Institute. I'm talking to you today about our new study on predicting low acuity visits to the emergency department using an algorithmic approach. Emergency departments today, all over the world, but particularly in the US, are in a little bit of a crisis. The emergency department has taken on a really central role in the healthcare system as we've moved more and more things that used to require multi-day hospital stays to day surgery, for instance. Those complications come back to the emergency department. And as primary care has gotten busier and busier, there's less availability for sick calls. So the emergency departments in the US right now are extremely crowded, that their waiting times are longer than ever. Waiting rooms are busier than ever. And it's not uncommon to wait 4 hours or even 8 hours in a waiting room while you wait to be seen in the main emergency department. The thing that keeps that safe, or we'll say less unsafe, is triage. So triage is a process where a nurse, an experienced triage nurse, sits up in the waiting room and listens to people's stories and takes their vital signs and assigns them a score. Typically, it's a 5-level score that determines how quickly you get seen in the main emergency department based really entirely on clinical factors. That score has a few problems, among them that there can often in this era be multiple people who are flagged at a high priority waiting for a bed, and it's unclear to know who among them to give the next bed to. And it can also be the case now that it can take some time to even be seen by the triage nurse because waiting rooms can get so overwhelmed. And so there's been a call for more algorithmic approaches to emergency department triage, but there are a lot of challenges to developing those algorithms. The goal of our study was to try to see if these algorithms that have been used for a long time extensively for research purposes and by some health insurers to identify emergency department visits that might have been able to be seen in other care settings like primary care or urgent care could be improved by adding additional information, additional covariates that are now available in other data sets, and through the use of a machine learning approach, so improved algorithms. In this paper, we sought to develop a better algorithm for identifying low acuity emergency department visits. And the reason why we did that is that these scores are incredibly widely used. So there's about 4,000 papers we have identified in previous work that use the existing approaches. And yet those existing approaches, we show if one of the existing algorithms declares an emergency department visit to be lower acuity, it turns out that there's only a 1 in 3 chance or so that that visit was lower acuity by our definition. And so the existing algorithms leave a lot to be desired. In this study, we used national data on emergency department visits to try and determine if we could take the existing algorithms, which are essentially lists of diagnosis codes, and add in additional information to improve the reliability with which they detect visits that are lower acuity. So the first approach we tried, really to test our hypothesis that your overall level of risk mattered a substantial amount, not just what happened on this particular visit, what you were diagnosed with on this particular visit, is we ran the algorithm with only age and sex to try to predict who had a lower acuity visit. And it turns out that giving the algorithm only the information of how old are you and are you and what's your recorded sex in the database is as good in performance as the existing algorithms using diagnosis codes. So that was our first real clue that we were onto something, that there was extra information there that the existing models weren't using that we could use to try and do better. And indeed, we found that when we added in more information, so we took all of the diagnosis codes that all of the previous diagnosis lists had created, and we gave those to the model as possibilities, in addition to age and sex. And in addition to some clinical information, like did you get a CAT scan, things that are available in claims data, the kind of data that insurers see, which is a much more limited view than what's available to the hospital in the electronic health record, that we found we were able to improve the performance by about 83%. And so now in our algorithm, about 2/3 of the time when the algorithm labels a visit to be lower acuity, it was lower acuity by our definition. It's important to note that 2/3 of the time being lower acuity is really good and very useful for many purposes, including quality improvement, including efforts to improve primary care or alternatives to the emergency department, and including research purposes. But it's not very good for many purposes, including denying claims and saying that you shouldn't have gone to the emergency department, because 1/3 of the time you were seen in the emergency department, 1/3 of the time that even our algorithm labels this visit as being lower acuity, you were seen in the emergency department and an experienced clinician thought you needed at least 2 tests, or that you were not appropriate to wait in the waiting room for an extra long time because you were triaged to the lowest level of codes.